So for today is our last session, and we've been together close to 2 months. So I'm so happy to see all of you here. And what I wanted to do today, as I said last time, is we're going to really start to apply the whole framework that we've been talking about for the past 7 weeks into some clinical material. But I did want to start just framing the whole course to see the larger context in which I see it fitting. And I did want to directly address the issue of trauma, because I alluded in the very first lecture to this idea of kind of in parallel with the concept of building a trauma-informed community to build an infant mental health informed community. So I wanted to talk about that a little bit more explicitly. So just, I'm going to share my screen. And just go through a few slides, not too many. Then we can jump into the clinical stuff, which is what it's all about. So just to reframe, like, what is the Hello, It's Me project that we've all been engaged in together? And really the broad view is that we want to create an infant mental health informed community, which involves us learning together as we have been, and ongoing collaboration, which we'll do in the coming weeks and months in the bi-weekly community of practice sessions, which I should add by popular request are going to be at noon rather than at 4 o'clock. And so we also really want to broaden our reach. I mean, I love this group because we have a very broad representation of different perspectives. I'd really like to bring in some more community leaders, including politicians, more healthcare providers, educators, and a range of others as we have these trainings and ongoing meetings and educational events in the coming year. And overall is to increase the focus on investment in young children and families as critical to growing a healthy community. So these are the core infant mental health principles that I've laid out for you together with my esteemed colleagues over the past 7 weeks, which include the concept of mutual regulation and dyadic meaning making, and how we make sense of ourselves in the world in moment-to-moment interactions, and the significance of giving space and time for safety, and in doing so to promote the capacity for reflective functioning, to take into consideration the biological vulnerabilities of the infant, keeping in mind the mantra of regulate, relate, reason, and supporting caregivers as neuroarchitects or building healthy brains and minds. So as I said, before we get into applying that framework to some clinical material, I wanted to call out this kind of reframing of the concept of trauma from the perspective of resilience. And I'm suggesting that all of what I've been talking about offers us really a different way to think about resilience than people might have, as neither something you're born with, nor something you acquire in the face of catastrophe, but rather it develops in these very moment-to-moment interactions that we've been talking about. That each time in a micro moment interaction with a caregiver, you get from a moment of disconnection to connection, to survive a difficult period in proportion to your developmental capacity to handle that, that's really where resilience grows. And Dr. Tronick uses this word quotidian, I love that word, or everyday resilience. So, and resilience is really woven into the fabric of your being in these hundreds of thousands of moments over time. So if we think of that being resilience, it leads us to have a slightly different perspective on trauma, because the word trauma itself, although this is not always what people intend when they use the word, suggests a one-time event or something that's circumscribed. But the thing is that for most people who experience what we might call trauma, that's their life. That's really just what their life is like every day. And it's a series of unrepaired mismatch, prolonged time to repair. So we can think of trauma also in this term every day. And I thought I would give you this example because, quite commonly people who have experienced what professionals describe as trauma, again, that's just their day-to-day experience. So they don't necessarily see that as trauma. That's the way they are in relation to other people. So I'm just going to read you this very short case, which is also in the text for the course, because I think it exemplifies this concept. When Frank was young and committed some typical childhood transgression, such as having a meltdown at a large family gathering, his father would shame him by sending him to sit on the bottom basement step, sometimes for hours at a time. As an adult, when Frank sought help from a therapist in coping with his increasingly explosive relationship with his 12-year-old daughter, Lindsay, he did not use the word trauma to describe his own childhood. This emotional abuse from his father was an everyday experience woven into the story of his life. So if we approach our work with this kind of new understanding of trauma, and personally, I don't really like to use the word trauma. It's a kind of othering. I think this is, a colleague of mine once said, what we now call intergenerational transmission of trauma is what we used to call life. So things happen. And the good news is that we have opportunity to rewire our brains over our entire lifespan. And while certainly if we do things when things get off to a problematic start, or we intervene very early, or support families even before there are problems, that helps brains grow in a healthy way. But what we've talked about in terms of meaning making shows us that what all of us are doing, and in fact, this group together is kind of a network of relationships for our community, because we have home visitors, we have early intervention, we have mental health practitioners, we have pediatric care providers. So all of us together create that kind of holding network of relationships that can help families who are struggling to be in the world in different ways. And there are studies showing that there are brain changes with a variety of different types of psychotherapy. And I would even, I don't know that there's specific research to this, but the word psychotherapy is fairly circumscribed. But I would imagine that if we expand that kind of research, that all relationships that we have the opportunity to change our brain. And so this particular body of research demonstrates that new relationships offer the opportunity to make new meanings and to rewire the brain. So what this all leads us to is kind of and I think, I don't know if, I can't see your faces, but I don't know if Linda's joined us yet, but you brought up when we were discussing postpartum depression, this kind of shift from the biological model of disease to see these kinds of struggles that our families have as a developmental process over time. And both our emotional well-being and emotional distress grow out of variations in repeated moment-to-moment exchanges that make each of us who we are. So you can have a person who on one end of the spectrum has a very positive core sense of self and characterized by hope and resilience. And at the other end is a person whose way of being in the world, because of restricted opportunity for robust mismatch and repair, is characterized by anxiety, rigidity, and hopelessness. But the fact is that all of us not only lie in between on this enormous spectrum, but we may shift in terms of the meaning we make of ourselves in the world, depending on what's going on in our lives and in our relationships. So I think all of what we've talked about can help us to see emotional health as a process that derives from change as we immerse ourselves in the network of relationships. And even though it has its roots in our earliest relationships, it can continue to be transformed over time. And that's really what all of us are doing from whatever role we have in relation to families. And I think it's important, if I'm going to help shift from this biological model disease, is to call out the issue of stigma, because I think, unfortunately, these things sometimes get swept up together. So I like to really name that if we are going to call attention to the developmental and relational context of emotional suffering, that does not mean we are stigmatizing emotional suffering. We are just embracing its complexity. And we've talked about in the course that, if we to call an emotional struggle a brain disorder and conceive of them as residing exclusively in one person, leaves out all of what we've talked about of meaning making in relation to other people. And we also talked about how that meaning making actually affects our genes and the structure and function of our brain. So I want to conclude, since I started, obviously, the reason we're on this virtual setting is because of the pandemic, and that's informing everything we do every moment of every day. And we all hear about this mental health crisis that we're living through, and that we will certainly continue to see reverberating into the future. And I think that it kind of demonstrates what we've been talking about, which is that we need a network of relationships to have a sense of ourselves in the world. And when we suddenly lose that, and our moment-to-moment interactions are very restricted, that can, especially in people who are vulnerable, lead to an unstable sense of self and identity, and some very deeply disturbing emotional experiences. But I hope, and you'll get, I hope, having known me for 7 weeks, some of you longer, that I tend to be a fairly optimistic person. And I wonder if this is an opportunity to eliminate the stigma of emotional suffering by recognizing that we're all vulnerable to this, and how important relationships and social connection are to our emotional health, and that we need to really invest in that for parents and young children especially, but really for all of us. So my hope is that that's in a small way what we're all doing, is that we are together in relationship with each other, making sense of some of the challenging experiences we're having, both personally and professionally, during the pandemic. And going to stop sharing now. So great, a lot more people have joined since I started talking. So now, as promised, I just wanted to give you that frame, but I really want to delve into clinical application of the concepts we've talked about. So Melanie, my co-faculty, is going to share a case. I'm actually going to, before I turn it over to you, I'm going to see if there are any questions or comments about what I've said so far. Okay. Okay, so Melanie, you're on.
All right, thank you. Good afternoon, everyone. I am the case that I'm going to present to you. I should probably have a little disclaimer to say that I saw this client some time ago, before I participated in the Infant Parent Mental Health Fellowship. And this is a case that has, at the time, was very challenging and complex, but now that I was able to kind of dissect it to share it with you today, I now can appreciate some of the complexity of it and wonder what I might do now differently if I were to go back. But I am going to share my screen with you. I kind of put this case into some slides to kind of organize the thoughts a little bit. Let me just get it set up. All right. So to give you a little background of this case, we're going to call her Maggie. And when clients are referred to our clinic, it is often the child is often the primary patient, and parents are usually the ones that end up referring. Maybe it's because of a discussion they've had with a pediatrician or a teacher, maybe even a psychologist. And so, how it comes to us as parents usually put some referral concerns. And so Maggie happened to be 4 at the time of the referral, and her parents were most concerned about her restricted eating patterns. She had lost a considerable amount of food options, and she was no longer trying any new foods. And she had while it wasn't in the initial referral, it was in some of the developmental paperwork that she had challenges with weight gain since early on. And so the makeup of Maggie's family, she has 2 parents. Both were on the older side for parenting. I would say they were in their early to mid 40s. Both were professionals. And Maggie also had a twin brother. They, the other information that was included in the developmental history was that she did receive some early intervention for some general developmental concerns, and it seemed to be mostly motor based. That was the concern at the time. So I actually happened to be the one that evaluated Maggie, and then I later was able to treat her, which isn't always the case. Sometimes the person who evaluates doesn't get to be the one who treats, just the way that our process works. But I happen to be able to do both. And so some of the things that kind of pointed out to consider, who she was from a biological perspective, or even considering some vulnerabilities. She was born at 31 weeks. It was a twin pregnancy, and they were born via C-section. Both babies were breech, and that was one of the reasons why the C-section happened. One thing I completely had forgotten about, but as I was doing this, she had a lung repair. I guess she had a collapsed lung, and that was repaired pretty soon after birth. And both she and her twin brother, spent about 6 to 8 weeks in the NICU. And it was reported that feeding was a challenge from the start, particularly weight gain became an issue. And so during the evaluation, before we sort of meet the child, the family fills out a pretty detailed developmental history, and they fill out a sensory checklist. And this helps us to kind of start putting some pieces together, and as well as sort of clinically cluster some sensory areas. And she did have a lot of what I'll call high reactivity to tactile experiences. And this wasn't just to food. This was to clothing. This was to, even bathing, showering, shampooing. They were all very challenging everyday experiences. She was particularly sensitive to certain odors, as well as visual appearance of non-preferred food. And during the evaluation, I found that she had some pretty remarkably decreased postural stability, mostly at sort of the neck and shoulder area. And she had a considerable amount of drooling that happened throughout the whole evaluation. And it was really interesting during an evaluation where we're looking at feeding. We look at a lot of the areas that support feeding, but we also do sort of an eating observation, and we have the parent pack a preferred food, which it was at the time, I can't even remember, it was probably crackers. And then I wouldn't call it a non-preferred food, but it's a food that they used to eat that they no longer eat, that we have them pack, not because they're going to be asked to eat it, but just to kind of, see their response. And she was immediately, when she saw the food that she no longer eats, she immediately sort of recoiled away from it, and she had a lot of autonomic nervous system responses. She became flushed, her breath changed. It was obviously a very dysregulating experience. So I knew that there was a high level of reactivity to how the whole eating process. And so like I said, I was able to be the treating therapist. And so one of the things that I sort of think about with, I'm not sure, I'm just looking at the slides here. One of the things I guess I forgot to put as part of the slide is how did I create some safety in the relationship? And so how sort of intervention starts is beginning with the parents' concerns and what is their vision, what are their goals for therapy. And then how do I think about bringing them into the process? And then what do I learn about their child? And so some of that happened over time as I got to know, Maggie and her family. And her dad actually happened to be the primary caretaker. And when I say that, they did have a nanny that kind of handled, I would say, the minute to minute things at home, but dad did mostly taking the children to appointments. And he was mostly the main communicator in the intervention. And he participated in some of these sessions. And so I got most of, my feedback from him. And so, as I started to get to know this family, I would probably, I started thinking about, what was it like being Maggie in this family? And I thought about dad, who he would describe himself as anxious. And that was one thing that came out. And this is how I knew the relationship was starting to feel safe. Dad was pretty button up and kind of, I would say, very goal focused, like how are we going to make Maggie's eating better? How are we going to get her to eat more foods? And, as he started sharing some more things about himself, about how he was feeling very worried and anxious about, the limited food choices that they had, also not wanting to upset her with eating. I kind of started to see a different side of dad, and knowing that I was getting a little bit more of a picture. And then I was able to meet mom on a couple of occasions. She was, here I kind of put, she was less involved in the day-to-day care. She had a pretty, from what I understand, a highly intense job. And it was mostly due to her work schedule. But, mom joined sessions. She was a very animated and playful person. But I would also, the way that I would describe both of the parents with Maggie is they approached her very tentatively. It was almost as if they were trying to minimize any moments that might upset her or make her feel uncomfortable. And I didn't entirely know what that was coming from. It was just an observation at the time, and even now thinking about it. But, as I was getting to know them and watching them with Maggie, and as I was getting to know Maggie, I did wonder about the parents' experience with IVF. They did not openly share this with me. I do know that that's how they were able to have these two children, but I'm not sure what that journey was like. I also wondered about the children's prematurity. Both children had some medical needs that were different at the beginning of their life. And what was that like for the parents and their transition to parenthood? Being older professionals, and this was a very different life altogether. I wondered what that transition was like. And so, Maggie continued in OT. It was probably 3 to 4 months in, and she was, from my perspective, she was making a lot of nice gains. She was eating or exploring new foods in the sessions, and we won't go into how we sort of systematically do some of the food work, but she was moving along as I would expect. What came along in different conversation was this was not being seen at home. They were still having some challenges getting her to eat non-preferred food, and they also saw challenges in just her hunger and how much she ate as well. So that was kind of lingering. And so considering where I was seeing Maggie, sort of my typical feeding, sensory motor kiddo, and the parents having almost a bit of a mismatch. We're not seeing it at home. We're not seeing, much improvement. We decided it was a good idea to have a sit-down parent meeting. While we had had sort of communication and dialogue all along, this was an opportunity where Maggie wouldn't be present. And this is where I learned of some new details that I wouldn't have known had I not sat down with them. They shared an experience that Maggie had when she was 2 years old. They had had nannies for the children since very early on in infancy. And they were not the same nannies. I think there were changes on a yearly basis. And the nanny that they happened to have when she was 2 force fed her. And, like I said, she was a kiddo who had a low appetite. She was a very slow, deliberate eater. And perhaps, I'm not sure the circumstances that led up to that, but the parents unfortunately walked in onto this nanny force feeding Maggie. They don't know exactly how long it was happening. They suspect it was not very long, but there was a lot of guilt around that experience. And, as a parent myself, I can't imagine walking in on and seeing that. They also shared on both sides of their family, they each had family members who had some significant eating disorders, mostly anorexia. And both parents thought that this was going to happen to Maggie, that because of her challenges with eating, it was going to lead to a full-blown eating disorder when she was a teenager. And hearing that information from them and how they made meaning of Maggie's eating and how I saw Maggie's eating change significantly. I now saw just how complex and complicated it was. And so what was really nice about the meeting, I appreciated that they were able to open up about these fears, I'll call them, worries, meaning making. And here I was able to kind of share a little bit more of Maggie's sensory vulnerabilities in what food and that experience is like. I did touch upon her early life experience in the NICU and wondered, I didn't make any assumptions, but just wondered what that was like. Interestingly, both parents didn't feel like that had any influence on Maggie. They felt that she was too young and probably didn't remember. But, it was sort of a question of wonderment, what was that experience like? But it was really from this meeting that, I called it our moment of meeting, where I was able to see them and where they were coming from and the meaning they've made of Maggie's eating. And we were able to take a very different approach as we moved forward. And so, this came to me as I was, putting this case together, was that, their worries became less intense, and that they were able to really see and understand Maggie's challenges, and not see them as, a potential eating disorder in the future. And so there was, with that information that they did share with me, at the time I did recommend that, we perhaps build a collaborative team and bring in a mental health clinician in this case, because there was a lot of, even though their worries had decreased, there was still a lot of that happening. And and I think that it was important to address some of that with a mental health clinician. This is where I realized the complexity of, this case, in that, I have a professional boundary which I can sit in, and I can't practice family therapy, but I did see that this is something the family would benefit from. And so they were able to be in touch with this clinician, and I had a couple of conversations with them. And, Maggie continued to make a lot of gains. I think that it wasn't, I wouldn't say that it was all wrapped up in a bow and puppies and rainbows, but it was an opportunity where the family really was able to understand her, and how these sensory motor components impacted the eating, how these past experiences impacted the eating, and then also how the parents thought and felt about, the eating experiences that they've had. And so she did continue to make gains, and we did feel like there was more mental health concerns at a point that we decided to take a break, and they focused in more on that at the time when some of her eating had stabilized and felt something they could, better manage. But that is, it was actually refreshing to kind of look at this in with a different lens overall, because like I said, this was a case that I had done some time ago, and I didn't have all of this knowledge or experience of the parent-child dynamic, but yet at the time I knew that there was so much of that going on and impacting the so-called referral concerns of her restricted eating. So that is the end of that slide. Oh, there's more people.
Thank you so much, Melanie. That was just a beautiful story, and brought in so many things that we can talk about. And I just like to open it up to the group for any reactions, questions, thoughts you've had listening to Melanie. Karen?
One of the things that I wonder about as I was looking at the history was the parents mentioning that Maggie had, that feeding was a challenge from day one, and she just has so many risk factors for having difficulty with breastfeeding. I don't know if she was breastfed or bottle fed, or if Melanie even knows how she was fed, but I just, the cesarean birth and and being premature, and, just lots of risk factors for breastfeeding difficulties or feeding difficulties right off the bat.
Yeah, Karen, I think that to answer your question, she was not breastfed. I think that I think she did have a feeding tube for some initially. Yeah, I mean, from the start, didn't probably ever coordinate that suck, swallow, breathe, which absolutely, probably continued. But it was not picked up until she was 4, that it was, quote unquote, a challenge at that point. So
yeah, I'm just going to make one comment, and then I'm going to go to Bob, which is that this course is called community supporting community parent infant relationships, but I think what this highlights is that really every case is an infant mental health case. I mean, I work with a psychiatrist who sees 17-year-olds, and I think when you can create that environment of safety where you can unpack the story from even before delivery and the infertility, and that it can inform your work no matter what age the child is. So that was very striking. Bob?
You're muted, Bob, just so you know.
You're muted.
There you go.
Yay.
Thanks, Melanie. That was well done. I think a couple of things struck me. You know, generally because of the type of work I do, you know, that's what, you know, one of the reasons I think I do a full lengthy history with parents, because so much stuff just connects, you know, in terms of meaning with our children and stuff. But I just was curious about one question. Do you understand how come they had a different nanny? You said they would stay a year and then leave. Did you have any understanding how come they had different nannies?
From my understanding, it was more the nannies that left. I think some of them were, you know, getting master's degrees and were moving out at the time. That was my impression. The one that there was a nanny that would bring them occasionally to, you know, to our center. She had been with them at that point for probably a year, and she continued until I had stopped seeing her. She was probably 6 when she stopped. So yeah, that was my best guess at this point, if I remember, but it would be an interesting question.
Yeah, I was just curious because, you know, there's a lot of times there's meaning behind that and sometimes it's not. Thanks.
I also just wanted to add, just working with new moms and babies, you know, as parents, we're just so vulnerable around making sure that they eat enough. And that starts from day one. And so I'm sure, you know, for that to be ongoing for both of those parents was really scary. You know, I feel like that's one of our most fundamental jobs as a parent, you know, is to be able to feed our children. So.
Yeah.
I agree.
I see that Sharon has a question. I want to just ask a question and make another comment. When you say they focused on mental health problems and shifted away from the sensory issues, can you just say what you mean by that? What mental health, in what way did they focus on mental health problems?
Well, they were started to be more concerned about her level of anxiety, Maggie's level of anxiety, and felt that she could make, you know, that she could make some continued gains overall with some level of support. She actually, there's a part 2 of her, which she did return later to our center, and you know, I'm not sure how it all ended, but it was, they were still a family that was pretty disconnected with her challenge, and definitely I think Dad had resorted to that this is Maggie's problem, and
yeah,
and you know, and did a lot of shaming of her at some point. So but they did end up with a very good mental health clinician who later worked with us too, and the family had ended up staying with for some time, and was working really hard to bring this family together.
Yeah, and I think what that points at is that when you do this very careful, safe work right from the outset, it allows you to get to where the problem really is more effectively. And I wonder about, you know, thinking about what Karen said about around birth, there's so much anxiety around just this very basic parental function of feeding your child, and that the early work of opening up a space of mutual regulation where she began to eat and their panic about her starving to death could begin to subside, and they could then begin to think about these deeper, more complex issues that really needed to be addressed. And we can also wonder about how addressing these things in real time early on might have affected her, versus by the age of 4, these kinds of ways of of characterizing things, people,
Mhm.
become more embedded
Mhm.
in the way you described the father. The father seemed like he was really trying to be reflective. Both parents were trying to be reflective, but they had some serious limitations in that.
Mhm.
So my hope
I
would
would
be
agree.
that in the more intensive mental health work, that there would be some effort to increase the parents' reflective capacity beyond sort of where they had stuck this child in their way of making meaning of her.
Mhm.
Um, okay, Sharon, did you want to? I see you have a long comment here, but I'm wondering if you want to say this out loud.
Yeah, I noted from the script that the father was described as anxious and spent most of the time with the baby, and the mother was more interactive with the baby, but not as available as much for that interaction. So I wondered about the attachment in the very beginning issues, and plus with the feeding issues from the get-go. And it just struck me because it's very similar to my experience as being a mother of IVF twins, and only the roles were reversed. I was the anxious one, and dad was not available, and he was a great dad, and he was very interactive and not anxious at all. So I'm just curious about that.
Yeah, and two babies at the same time. So what was that like? I only had one baby at a time, and that was a lot. So I can imagine two with two very different needs.
And then the cultural piece with other family members, particularly a mother-in-law who's got these ideas of how a baby should be fed, and this pressure to feed, which
Mm.
we all know now, years later. And fortunately I had the intuition that was not a good thing. To get that oatmeal put into the bottle. That was the thing back then. This was 26 years ago, but that sort of pressure
Mhm.
from other family members, that so it really struck a nerve for me, this story. And I just wondered what others thought
Mhm.
about this attachment and this issue from the very beginning with the feeding.
Bob?
Um, well, I was going to piggyback something what Sharon just said, not exactly answering a question, but there's a lot of discussion about the attunement with the child, but from my experience, I work a lot with kids with significant attachment disorders, and another big part of this is the attunement with the parents to each other. Like for instance, if you have one parent, like the mom in this case was more playful and interactive, but out of the house a lot, and dad's very anxious and at home a lot, and certainly that plays a part in the connection with the child. But one of the things I see a lot of is whether it's critiquing, whether it's not on the same page, like maybe for instance, mom giving dad more suggestions instead of seeing his struggle, or dad how he feels about mom not being there. And there's a whole nother piece with this, with parents' connection with each other and being on the same page and validating each other. That I think plays a lot out when you have a very stressful situation that's actually been ongoing with this from the moment of
Yeah.
Yeah, it's such a good
Absolutely.
point. Yeah. Yeah, I'm not sure I could articulate what their dynamic was like together. So yeah, it's such a good point.
I don't know about all of you, but it's extremely common, again, once you have a point of entry, to get people less terrified. Things begin to settle out. Like, where is the problem located? And I would say a great percentage of the time it's in the couple. And that the child's behavior is reflecting their distress at the discord and in the caregivers. Do other people have that experience?
I think just to kind of elaborate on that, what I liked about the presentation, Melanie, was, you described parents who are very sort of problem focused or goal focused on what they'd come to seek you out for, right? The feeding behavior. And in sort of presenting the story to us, you said that when they got comfortable and they started sharing these other things, there was the broader sort of canvas of the problem. And I do find that to be sort of the case of our work, that the referral that we get with the identified problem is very often, a conversation we have for the first couple of months. And then sort of the real things that we're working on are these deeper things that they only feel comfortable sharing as the relationship goes on. And that slack is really the work and not a sign that we're getting off track.
Yeah,
Right.
exactly.
Yeah, such a good point.
I missed a piece of it because my internet cut out, so I'm not sure if this was talked about, but I saw the bit about attachment. And some of the research that I've read is saying that eating disorders, they're suggestive of some sort of concern regarding attachment. And so it makes me curious what the parents' attachment was to their parents and how that is impacting their relationship with the child.
Yeah.
Yes.
I'm sorry, Melanie, you go ahead.
Oh no, I was just gonna say there's so many areas to wonder about with it. And these are times I wish, boy, what would I have asked them now, knowing this information. And Lynn, that's such a good point, thinking about, what was food like, what was eating like, just for them separately and their life experience.
And, that makes me think of a couple of things. First of all, what you said about lanes, I want to emphasize how all of us have different lanes from which we approach families, that all are important in their own way. And that kind of way that your way in was really focused on the sensory issues, but that by addressing that, you could bring in the more, I would say, purely mental health issues. But then, and so I think, Lynn, what you're saying is that kind of then the next layer of that is where there is space for a safe and more in-depth, over time, exploration of intergenerational meaning of feeding behavior. I mean, we don't even have to use the word attachment, but that feeding throughout our lifespan is so embedded with complex meaning, so that in order to address the behavior of eating, all of these things, including the past generation relationships, are definitely relevant. Yeah. Yes. Great question. I didn't see the whole thing. But I always find it fascinating that there are twins and one of them is identified as the problem. So Becky, go ahead.
There you go.
Yeah, I have this right now. I have 27-month-old twins that I've been with since birth. And I have just acquired a second set of 15-month-olds. Each one of the sets of twins has the eating issue, and the language is, their receptive language is phenomenal, but the expressive language for each one out of the two sets of twins, the 26, 27-month-olds is down to about a 15-month level. And with the 15-month-old, you've got one that's starting to make some sound production, and the other one is zip, but the unwritten, I don't know, I call it twinnies between them, is just insane, because I can ask them anything or ask them to do anything or get anything. And that receptive is right on with each of the two twins that I'm concerned about. But the expressive, zip. And I went through every physical aspect, checking, have they been to the dentist, making sure that they're not tongue-tied, going through everything with each group of kiddos that I have here. And both of them are very, very tactile defensive and talk about throw them off, bring in for each of them something, a non-chosen food, and my visit goes, it's done. It's like, it's off the charts done, because they hyper focus on that non-preferred food, and we're done. And that's both the 27-month-old and the 15-month-old group. It's crazy.
Lot there. Bob,
You're
did
all
you
making me very thankful that I see babies at the very start where they don't have 4 years to to sort of form these patterns and then have to unwind them. That's not to say that it's always easy, and again, like a lot of times there's this you know, there for a lot of families there is either multiple miscarriages or, you know, like previous problems with other children, you know, like everyone brings something to the table that that may influence that relationship before the baby's even there, but certainly there's less time for that to have developed when I see them. But I think it just reinforces how crucial a lot of the way that we help parents see the baby in the very beginning can affect things down the road. And that goes from everything like, you know, preventing and then recognizing, you know, what some people call birth trauma, like what happened like at the actual birth itself, to the first couple of weeks postpartum, where a lot of families are struggling very much so, and do internalize problems that they have or the baby has, or failings of the system that they should have been able to rely on as their own. And yeah, I think it's just important to consider. So thank you.
appreciate that plug for getting in there early?
Exactly.
As early as possible.
You have such a wonderful perspective on that.
It's, you know, I've been doing it for 8 years, and sometimes it's still really frustrating to feel like I have to convince people that it's important enough. I'm still like piecing together multiple jobs in order to like make a living, and it's like, oh my gosh, people, this is so important to families. Like, just let me do my job.
So important. You know what you do, if we look at the, you know, at the future investment, it's so worth it to have 10 Nicoles in every community spending time in terms of the kind of prevention that we can do. But unfortunately, that's not yet well known, but that's what we're all here for, to
Thank you so much.
know about that. I saw somebody else who I haven't heard from. Carolina?
I put in the question, I was wondering if there are any studies around, you know, preemies or NICU and the eating difficulty, because apparently it's very common, though I hadn't really either seen it or paid attention to it. But certainly the NICU when sensory struggles later on that you could recommend.
There are actually a lot of, there's been more recent studies of some of the sensory presentation, and a lot of them are from premature infants. I can try to get some out to the group.
Yeah, and I think there's also literature more from a psychodynamic perspective of you know, when there's fears of, you know, the vulnerable child and things like that, and how those also play in. So I think you can address it from several different angles.
Exactly, as well as the parents' experience with the NICU and what that was like. But you know, going back, a lot of the clients that we see with restricted eating, very often, I would say probably 75% of them, there's something early on in their history. Not all of them are preemies, but there's, you know, even I would say minor, moderate kind of things of, you know, challenges with breastfeeding. There was, you know, latch issues, you know, tongue tie, early tongue release. And I wonder how that repair was, you know.
Great.
So.
This is so rich. Bob, I know you've had your hand up for a long time.
Oh, that's okay. Well, just something that was said earlier, you know, I found parents are more willing to talk about their issues and their parts than we realize. I think to me, one of the struggles, because I come from an old way, And, you know, when I watch a lot of, you know, young therapists today, and, you know, there's so much emphasis on what the problem is or what the behavior is. And even in a lot of clinics, it's all these checklists that you fill out, and you lose sight of the everyday, you know, things. You know, after my first session, which I spend most of my time listening to parents and allowing them to ask me any question they want, you know, when I tell them I want to get some background on them because it just helps me understand it. Even something as simple as I'll ask, you know, what were some of your fondest memories as a child? It just opens up all these doors that they allow you to go through, you know, because we're always, even when taking a parent history, we focus on what their problems were or this or that, and instead of their fond memories and who supported them, you know, who's there for them. And it just opens up all these doors. And I think there is a struggle in our society on how to engage with a person and a parent in order to get what information, and not everything, because they're not going to give you everything, and that's okay. But that also helps to establish that rapport and that relationship. And I think that's something we lose sight of.
Well, Bob, I think that's just such a beautiful way to close out our 7 weeks. And I think, you know, I would just reflect that really all of you do such beautiful work already. And what I hope we've offered is kind of a frame for thinking about the work you already do. And perhaps, certainly this was true for me, doing it in a more deliberate way that pays attention to these different ways of understanding relationships and development. So I feel like once we get into the clinical material, we could go on, and that's what we're going to do. So every other Monday, starting January 4th, and the consensus, as I said, of the whole group, including the people who were in it before, is to do it at the noon hour. And it's really a drop-in kind of thing. If you have the time, we'd love people to join us. And just to emphasize, and Melanie shared this with us before when we were just, the faculty were just having a conversation, that all of this material really is something that is integrated over time and continues to change. And I find that the more I learn, the more I think differently and have a more complex approach to things. So it's really a process, and I hope we can embark on that together. And I would also add that I'm going to soon begin planning the next one. We do this every 6 months. And I really want to begin to broaden our local community. So if you have colleagues or friends who you think would be interested in joining this project, you know, you can give them my email or to Grudy or reach out to me, and I can connect with them. So just keep that in mind. I hope to see you all in the new year. So
Thank you. Enjoyed it, Claudia.
Great. And thank you. Thank you. It was great spending time with all of you.
Thank you so much,
Thank you.
Claudia. And to all
Thank
the
you.
Oh, thank you.
Thank you.